Recipient operations follow on as closely as possible from the donor operation in order to minimize the cold ischemic time. In this lecture, we will give a brief overview of some of the organs transplanted. This will give you an understanding of the various surgical aspects of these operations and their expected outcomes. For the heart, a midline stenotomy is made and the pericardium opened. The great vessels are dissected out and the patient is placed onto cardiopulmonary bypass as for any other open heart operation. As time is critical in this operation, it typically begins as soon as the donor heart has been seen by the procuring team and they have reported it to be in a good condition macroscopically. The diseased heart is removed after cross-clamping the aorta by transecting the great vessels, the aorta, pulmonary artery, superior vena cava, SVC, and the inferior vena cava, the IVC. The 4 pulmonary veins are left on a cuff of the left atrium. The new heart is then sewn in, first the left atrium, then the pulmonary artery, the IVC, the aorta, and finally the SVC. The aortic cross-clamp is then released and the heart filled with blood from the bypass machine. The heart is warmed, and when beating strongly enough, the patient comes off bypass. In 50% of cases, electrical cardioversion is required to get the heart started. The sternum is closed with wires and the skin with stitches or staples. This operation typically takes 3 to 4 hours. It can take longer if the patient has had previous surgery. The patient is in ICU for 3 to 4 days and discharged home after 10 days to 2 weeks if there are no complications. This is a high-risk surgery with a 30-day mortality of between 5 to 10%, but 1-year survival is good. 80 to 85% of patients will live that long. The average heart transplant patient gains 12 years of good quality life. Heart transplant. Cold ischemic time, maximum 6 hours, preferably under 4 hours. Recipient operation, 3 to 4 hours. Length of ICU stay, 3 to 4 days. Length of hospital stay, 1 to 2 weeks. Estimated 1-year survival, 85%. Average number of life years gained, 12 years. With a liver transplant, a large subcostal incision is made and the diseased liver removed. Previous surgery can complicate this operation as well, and major bleeding can occur. The liver is the organ responsible for producing the majority of your clotting factors. The anhepatic phase then follows while the liver is being sewn in. This requires close monitoring and management by the anesthetic team to support the patient. The inferior vena cava is sewn in first, followed by the portal vein. The liver is then reperfused. This is then followed by the hepatic artery anastomosis and finally the bile duct. These last two are the most likely to complicate. If the hepatic artery clots acutely, an urgent retransplant is required. This occurs in 2 to 3% of cases. The bile duct anastomosis is prone to delayed complications, such as strictures, and these may require later interventions. Liver transplants can take 4 to 14 hours. The recipient typically spends a few days in ICU and over 10 days in hospital. Complications occur in about 15% of patients. 1-year survival is 90% in good centers, and the average patient survival following a liver transplant is 16 years. Liver transplant. Cold ischemic time, 6 to 10 hours. Recipient operation, 4 to 14 hours. Length of ICU stay, 2 to 3 days. Length of hospital stay, 2 weeks. Expected 1-year survival, 85 to 90%. Average number of life years gained, 16 years. For a kidney transplant, an oblique lower abdominal incision is made to allow extraperitoneal exposure of the iliac vessels where the kidney will be given its new home. This extra anatomical position is used as surgical exposure is good for the vascular anastomoses and it is close to the bladder for the ureteric anastomosis. The kidney can be biopsied easily in cases of suspected rejection because it sits just below the abdominal muscles. There is no need to remove the native kidneys unless they are causing ongoing problems. Jonah Lomu, the New Zealand rugby player, had his renal transplant placed in the normal anatomical position to allow him to go back to playing contact sport. This is technically a much more difficult operation. The normal operation takes about 2 hours, and patients will be discharged after about a week in hospital. They require daily monitoring of kidney function, looking for any signs of rejection. Over time, the immunosuppression can be tapered, but it is still required lifelong, as with all transplants. Kidney transplant. Cold ischemic time, 24 to 36 hours. Recipient operation, 2 to 3 hours. Length of ICU stay, not applicable. Length of hospital stay, 1 week. Expected 1-year survival, 95%. Average number of life years gained, 9 years. The lungs. Lung transplants can be either single, 1 lung, or bilateral, both lungs. Bilateral lung transplantation is associated with improved long-term survival compared with single lung transplantation, and is currently performed in the majority of adult lung transplants. The patient is intubated with a double lumen endotracheal tube, a bilateral sequential operation, where each lung is implanted separately, is the standard approach, and is performed via 2 anterior thoracotomies. Occasionally, a transverse thoracostenotomy, clamshell incision, is required. Where a single native lung is able to support oxygenation, the native lung with the worst function is removed first, while 1 lung anesthesia is used on the contralateral lung. After implantation of the first graft, 1 lung ventilation is switched to the new lung, and the second lung is transplanted. If single lung ventilation is not possible or hemodynamic support is required, cardiopulmonary bypass, or VA ECMO, can be used, requiring the patient to be heparinized. The new lungs require 3 anastomoses each. These are done in their posterior to anterior anatomic sequence: the bronchus, the pulmonary artery, and the pulmonary veins to the left atrium. On completion of the procedure, 2 chest drain tubes are placed in each pleural space, and the chest is closed. The airway is inspected endoscopically, anesthesia reversed, and the recipient is transferred to an intensive care unit. Long-term outcomes are not as good as other organs, impacted by a condition called bronchiolitis obliterans, where there is progressive loss of the smaller airways in the lungs due to chronic rejection. Lung transplant. Cold ischemic time, 6 to 8 hours. Recipient operation, 4 to 6 hours. Length of ICU stay, 3 to 5 days. Length of hospital stay, 12 days. Expected 1-year survival, 90%. Average number of life years gained, 7.5. The pancreas is transplanted for insulin-dependent diabetics, either simultaneously with a kidney transplant or after a kidney transplant. This is because immunosuppressive treatments impair renal function, and the increased risks associated with taking these drugs are currently only justified if there is already a need for a kidney transplant and immunosuppression. The surgery involves extensive back-table reconstruction of the blood vessels prior to implantation, which typically takes place on the opposite side to the kidney transplant. The pancreas is similarly anastomosed onto the iliac artery and vein, with a cuff of duodenum being anastomosed onto a loop of bowel. Pancreas transplant. Cold ischemic time, 8 to 14 hours. Recipient operation, 4 hours. Length of ICU stay, 2 days. Length of hospital stay, 2 weeks. Expected 1-year survival, 85% for simultaneous kidney pancreas transplants. Average number of life years gained, 1 to 2 years, in addition to the renal transplant benefit. Small bowel transplants are only indicated in patients who have failed home TPN, or home intravenous feeding. In cases with concomitant liver disease, a small bowel transplant can be combined with a liver transplant. Patients will receive a stoma to facilitate endoscopic monitoring of the graft, and survival approaches that of lung transplants at approximately 7 years. Small bowel transplant. Cold ischemic time, 8 to 14 hours. Recipient operation, 8 to 10 hours. Length of ICU stay, 5 to 7 days. Length of hospital stay, 4 to 6 weeks. Expected 1-year survival, 75%. Average number of life years gained, 7. To recap, all transplant surgery is best performed at specialist centers with dedicated transplant teams. It is highly complex surgery, and close follow-up of patients and their immunosuppression is required to ensure good outcomes. The results are incredibly satisfying.